laws. Additionally, we take an all-crimes approach at the 20,000 ABC permitted businesses across the state, as well as the 7,000 lottery permitted businesses across the state. I have 111 sworn positions. I have about a dozen vacancies right now. Just one moment to brag, we are the only nationally accredited alcohol enforcement agency in the nation. So we take great pride in doing things the right way and making sure our policies are in compliance with best practices across the country, as well as our training. I am here this morning to discuss briefly with you some of our observations about Tianeptine. And I want to start with a disclaimer. I'm probably letting you know of something you already know, but Tianeptine products are not unlawful in North Carolina. So they are being sold at convenience stores, but we're really seeing them widely available at vape and tobacco shops across the state. The information I'm going to be presenting this morning is really our observations with that, realizing that we are in these businesses in and out every day, but we have not, other than what I discussed, we have not really taken a deep dive on Tianeptine, again, because it is not unlawful. We have finite resources. We try to prioritize those resources. I will say, based on our observations, the products appear to be more widely available in central and eastern North Carolina. The further west you get, the less that we're seeing it, although it is present. Late last year, we did get a complaint of an unknown product being sold at a store in eastern North Carolina. We did do an undercover purchase at that store, and we submitted that product to a private lab that we use for some of the THC quantification. They did test the product, and it came back positive for Tianeptine. But there were no other controlled substances in that product, and for that reason, our investigation concluded right there. This committee may already be aware, but open source reporting indicates that there are several names that Tianeptine goes by in the businesses. Neptune's Fixed, Tiana, gas station heroin, gas station dope, TD Red, Zaza, and Pegasus. We see Tiana is here on tobacco shops on like external advertisements, and that's what they're referring to as Tianeptine. Some of the photos our agents took at the products across the state, as you can see, I've got photos from Fayetteville, Salisbury, Creedmoor. And what we're seeing is the cost, although it does vary a little bit, we're seeing about $30 to $40 for 15 capsules. And these products come in 15 capsule containers. These products were in Wilson. I've got Waynesville, Aberdeen, Hillsborough as well. A lot of the products don't really have a lot of specific information in there, like how many to take and how often to take it, although there are some websites that you can go on and show that, they advertise you can take one capsule 3 times daily. And they do come in 15, 30, and 60 capsule bottles, but again, we typically see them in the 15 range. And that completes our observations on Tianeptine. As I said, I wouldn't come up here and talk very long. It's just our observations of what we're seeing. I will turn it over to Mr. Chair.
Let me hold you here just a second, if I could. Are there questions for Director House from Representative White?
Please forgive me for being a little bold, but Mr. House, I do have a question for you. Who is Miss Teen America?
So Miss America's teen for 2024 is my daughter, Hanley House.
Thank you very much.
Takes after a mama, right?
Amen, sir. Amen.
And they will be coming to the chambers to be honored a little bit later.
Didn't realize we had celebrities in the house today.
Did I mention he's one of my constituents?
Representative Sasser.
Thank you, Mr. Chair. Mr. House would like to commend you on the great job that your agency does. I like to tell people, if you do what the law says you're supposed to do, y'all are the nice guys. If you break the law and do illegal things, y'all are the bad guys. So the people of North Carolina thank you for the hard work that you do. And we need to and there's none of our Senate colleagues in here, but they need to pass House Bill 563 and allow y'all to regulate these vape shops, which are a scourge on the state of North Carolina, because we're allowing them to operate, do illegal things, and we're not doing our job to allow you to regulate them. And we need to add Tianeptine to that piece of legislation. So everybody call you Senator. Let's get this bill passed and allow these fine people to do their job. So thank you, sir.
Other questions? Representative Baker.
Thank you. I apologize for getting here late. I was at a community meeting last night with our Forsyth County Department of Health, and they talked about how potential overdoses get logged. And one of the things that stuck out to me, and this may not be a question that you can answer, is that when they suspect that someone has OD'd either from something from the counter or another drug, the way they log it is if the person calls and complains of chest pain, and once they get there, they say that maybe some drug use was involved. They log it based on the chest pain, and there is nowhere for them to log that a potential drug was used. And I don't know where to go with this, but I know we had this meeting today. They say that they only look at the first issue that's logged, and so we don't have accurate numbers of how bad overdosing is and how bad the actual usage is. So do you know if if there's a way that we can now add a secondary box for them to add when they arrive at the scene, that if it's chest pain and drug use is indicated, that both of those are indicated as primary, potentially primary issues? I'm not sure if I'm explaining this right. And I'm not sure if you're the person that I should be directing this question to.
I'll say the short answer is I'm probably not the correct person to direct the answer to. I will say from our observations sort of in the same space and trying to regulate some of the industries, there are challenges with getting the information we need. For example, a lot of the THC, overdoses or hospitalizations, we only get that information if it's reported to us from our chiefs and sheriffs. Thankfully, we have great relationships with our chiefs and sheriffs, and they do report, but there's no consistent way of obtaining that information, as a user.
So follow up, Mr. Chair.
Follow up.
So in the scope of what we're looking at on this substance abuse committee, could we include that as a possible avenue that we should take into consideration?
Yeah, I would say we could, because obviously we need to have accurate data. And if that's something that's kind of skewing data, then that's something we need to take a look at.
Thank you, because he did say that that they put it in the narrative, and so in order for them to kind of figure out how many of those instances are related to drug use, someone would have to go back to the narrative, and so thank you.
That's a good question. Thank you. Any others? All right. Thank you, Director House. And I just want to say I had an opportunity yesterday to see ALE agents in training down at Samarkand. And it's an impressive facility, impressive training program. And there was some really strong agents down there working hard to be polished and able to do their jobs. So we're very fortunate in North Carolina to have that kind of facility. Next, we have another substance that's been brought to our attention by the North Carolina Chiefs Association. We're going to have a little bit of discussion about that this morning. And I had first up this morning was Chief Shane Guyant from, and I don't think he's here, but I've been informed that Chief Richard, is it Kellum from Jacksonville, is here and can speak to this issue in his place. So if you'd come up.
Mr. Ross, I want to thank you for the promotion. I'm actually only a captain.
Oh,
Sorry. And as I said, I'm only a captain with the Jacksonville Police Department. Chief Mike Unero asked me to be here today. He has a lot of interest in the Xylazine. I did spend quite a bit of time in narcotics enforcement in my career, and we've been dealing with Xylazine in Jacksonville. And for those of you who may not know, Xylazine is not controlled in any way. It's not scheduled by the federal government. It's not scheduled here in the state. It was never approved for FDA use. It was developed by the Bayer company with the intent of potentially having human use, but the FDA never approved it. It's only approved for veterinary use. Unfortunately, across the state and across the United States, we've been seeing a lot of Xylazine as included with fentanyl. So one of our big concerns with that, because Xylazine is not a narcotic, naloxone is not effective. Xylazine depresses the heart rate. It's a hypotensive, but it depresses the heart rate, slows breathing, and could even stop both. So we have some pretty serious concerns about it. Now, in Jacksonville, and I can only speak to Jacksonville, North Carolina, we have made great strides in reducing the fatalities from overdoses. All of our officers carry naloxone, and we administer it quite frequently. I think we had 350 last year, only 26 overdose deaths. That's been quite an improvement from what it was in the past, but our concerns are, because naloxone has no effect on Xylazine, that when you have both of these drugs together that are effective, the effectiveness of the naloxone will be reduced, and our overdoses are going to increase. We would ask, and speaking for Chief Unero, we're hoping that the state would consider scheduling it. I know that the federal government is already considering scheduling Xylazine. We've done, there's been similar movements in the past. Xylazine is not an analog of any other drug, so our analog laws don't affect it. Unfortunately, it's the only control on it at all is a federal restriction to only veterinary use. Unfortunately, us in the state, we can't enforce those laws. So we have no control over Xylazine whatsoever. We have limited ability to test for it. We do get reports back from the state crime lab. They're pretty amazing about trying to identify emerging threats. And so that's how we know in Jacksonville we've had some overdoses that involved Xylazine or seized heroin fentanyl combinations with Xylazine. Yes, ma'am.
Do you have, not to say that you should know this, but if you heard it on the streets or wherever, have you all understood, or do you know how the cartel just brought it out of the veterinary practice into, I know that they don't have to have reasons for doing things, but I just wondered if you kind of knew any history about that.
It's not only coming through the cartel or the typical trafficking routes. This is something, before coming to this meeting, I asked some of my narcotics units or narcotics detectives just to look and see if they can order it on the internet, and you absolutely can. They found bottles with Cyrillic lettering on it, so probably coming from, country in another country. You can order it from China. It's available pretty readily over the internet. Obviously, just like ketamine we saw years and years ago, it is diverted from veterinary medicine some, but I think that's not the biggest problem. I think the biggest problem is where it's coming. You can order it on the internet.
Thank you.
Yes, ma'am.
Thank you very much. Just wanted to get an idea of the youth component to that. High schoolers, I know that Tianeptine is being used by the younger people. Is this also being accessed by young people?
So one of the many scary things is, young people, unfortunately, are using fentanyl and heroin and those drugs as well. The buyers, the people who are purchasing fentanyl, again, I said there's no field testing, or it's very limited availability of any kind of field testing. I think in 2019, you guys here in North Carolina took field test kits away from made it basically legal to have those. So users could actually test the drugs that they're using. Maybe not, that was the only reason, but users are able to test the drug and see what they're getting, so they can kind of protect themselves. In this case, they're not able to do so. So my concern with the children is the children who are young folks who are using heroin, fentanyl, are going to be exposed to xylazine the same way.
Follow up, please.
So the use of Tianeptine by young people is a fairly new phenomenon, at least in my world,
Right.
which is why we are doing this. Is that the case where you are? How long have you been looking seriously at not just Tianeptine, but also the Xylazine as a problem?
So I think there are two different things. We in Jacksonville have actually, with the aid of ALE and some other agencies, Department of Revenue, we have taken a pretty proactive path towards trying to limit the vape shops' availability of some of those controlled substances. In Jacksonville, we had undercovers go in and buy all kinds of different packaged materials. You've seen the packaging, not just those bottles, but some of it seems obviously geared towards children to me, with cartoon characters and things like that. We sent them to the same lab, Avazyme, that the ALE uses. It's a private lab. It was quite an expense to the city, but we sent it to that lab. And almost everything we sent came back as a controlled substance. Generally, most of it has been THC, marijuana. But they're openly selling it in our tobacco shops and vape shops. A little bit different from what we're talking about. We also found some, synthetic cannabinoids, which have been around for some time. They're controlled as well. And they're selling some mushroom candies that contain psilocybin mushrooms as well. So not necessarily a Tianeptine, which I'm familiar with. I learned something from ALE today about Tianeptine. It's not something we've tested for. We haven't received that complaint, but we've received a lot of complaints on the vape shops and trying to deal with openly selling what they claim to be hemp, and it comes back from the lab as being well above the 0.03%. That's legal. I hope I answered your question. Yes, ma'am.
Yes, thank you. Regarding the xylazine, does it come in, how do I say this? So when people purchase it, whether it's online or wherever they get it from, is it ever cut? Do you find that it's cut with something else, or can it be? Or is it, how
Yes,
pure
ma'am.
is it? And does that make it, but I would assume that it makes it even more dangerous.
Yes, ma'am. So, and that's what we're finding with the xylazine is that we're actually getting it as a cut for heroin and for fentanyl and some of the other drugs. So it's not so much that we're seeing it independently as much as we are seeing it as a cutting agent. And, it can be ordered in liquid form, powder form, or capsules on the internet. Even if you get it in liquid form, you can reduce it to a powder by cooking off the on a hot plate. I'm sorry.
Thank you. Thank you. My question is in reference to the xylazine. If you're talking about scheduling it as a controlled substance and it's coming in through the internet and all across the world, it seems to be that it would be very difficult to do, to control it. Once you schedule it, that's an additional space that you all have to enter in to control it and monitor it. But also with the trend, xylazine may be for now. And then in 6 months, it may be something else. It changes and it's so fluid. And we're seeing the overdoses with the xylazine in it and test strips now for that. But it's changing so often. So once you put it on that controlled substance, that's a whole nother ball game when it shifts, and that's no longer the primary item that they're cutting with or that they're using. So I'm not sure if that's the move to make, because once you get it there, it's very hard to get it off because you have to go through so many steps to do that. So that's one issue. The other issue is when they do overdose and the xylazine is there, it increases the use of the Narcan, which the Narcan may not totally reverse, correct?
Correct. The Narcan or naloxone won't reverse the effects of xylazine because it's not an opioid. It works differently in the brain.
And I noticed that the breathing, of course, it's almost like similar to morphine. It decreases blood pressure, it decreases the breathing and everything. And it's advised that you want to give people breaths, right?
That's correct.
Well, I don't think people want to be giving people breaths now with the COVID and all of that, because I have seen someone go out and I've stopped to help, but I don't want to put my mouth on them. Because you don't know where they've been or what they've been doing, unless it's another option available in the community, like the test strips being available to people that are using. It's a harm reduction, but it puts it in the hands of the user or the person that's using the drug. So I'm trying to figure out, where are we trying to find a balance, because of HIPAA and all of that. There's a lot intertwined in it. And when Representative Baker brought it up about what you're collecting when the EMT arrive, they're not going to try to collect. They want the primary reason that they show up. Once they get to the hospital is going to make the diagnosis of what the true cause of it was. Thank you.
Is not being uploaded for the tracking, and so that's why they were saying we don't have accurate numbers on that.
So,
and another follow up to what Representative Cunningham was talking about. I know what the reason the meeting in the community last night was to get out the information that the
Tianeptine.
The
naloxone.
Yeah, they're trying to get it out to the community that they have these kits. I took 3 of them. One for that. They want people to know that they have these kits. Anybody can access them from public health to have in case of overdoses. I guess if we move towards the testing strips, could that also be something that would be readily available?
Yes, ma'am.
Well?
Again, as a lowly captain in law enforcement, I would argue that both harm reduction and enforcement are very important to try to reduce harm to our communities. To speak to the scheduling and the concerns with I think North Carolina has done an amazing job with our analog laws, right? So, a few years back, I was on the front lines for the cannabinoids and bath salts, cathinones, and when we passed that analog law, it was amazing, and it gave us the ability to get them out of the gas stations, right? So they were selling them openly, and then just like you said, law enforcement, we typically are a step behind, so they would change the chemical compound and sell it again legally in the same store that I had just arrested somebody out of recently. But that analog statute made it so that we had pretty broad powers and had the ability so that we could keep up with the chemists wherever they are. it gave us that ability. But yeah, distribution of naloxone is an amazing thing. We do it in our community. It saves lives. Law enforcement carries it. We administer it quite a bit to talk about your numbers and keeping track. So we respond to trouble breathing, chest pains, or somebody who knows that they're overdosing, and we respond out. And if their breaths get under a certain amount, or if we're not getting a pulse, we administer naloxone, and it has. We have saved lives, guaranteed. If nothing else I've done in law enforcement hasn't saved a life, that has. Yes, sir.
First of all, thank you for being here today. Thank you for your information. I'll just make an observation. You're a replacement for, I assume, a police chief in Roanoke Rapids, but if it's in Roanoke Rapids, which is up on the Virginia border, and it's in Jacksonville, North Carolina, then it's everywhere in North Carolina.
I would agree, sir.
Point needed to be made. It's not just in Jacksonville. We're going to need some help how to add this to House Bill 563, because the problem I see with it, since it is legal as a veterinarian product, we can't just totally outlaw it like we can the Tianeptine. Got any suggestions? Do we need to look at other states and see what they've done with it? Or
yes, sir. I know that it's my understanding that a bill has been presented at the federal level to make it a Schedule III controlled substance. That's because it does have a use. It is not an opioid. So again, as a lowly captain looking at it, I would agree that would probably fit. And if it is scheduled, in addition to our analog laws, that would give us the ability to try to intercept those packages. Right now, if I got a crate of Xylazine in pill form, there's nothing I can do with it. Let the person continue to take it wherever they're going. Maybe I can follow them and see if they're going to put it in heroin or fentanyl. But for the most part, there is no legal action that we have, no control we have over that substance as a law enforcement agency.
I'll make one more statement and I'll shut up. Thank you for telling us to do our job so politely. Okay, so we do appreciate it.
I apologize.
No, you don't need to apologize to us. You need to hammer down. Thank you very much.
Thank you, sir.
Thank you, Captain, and I think maybe you'll be chief fairly soon. I just will make one observation. The chief that was scheduled to appear from Roanoke Rapids was going to talk about overdose deaths that they've actually had in Roanoke Rapids from the combination of the Xylazine and the fentanyl. So I think the issue there is when it's mixed, the Narcan, which does save lives, doesn't work. And so I think that's their growing concern going forward. And now to dig in a little deeper, I've got a real expert here from the UNC Gilling School of Global Public Health, Dr. Dasgupta. See if I can say it right. Dasgupta is here and is going to give us a little more technical definition of this whole process.
Good morning. Thank you, Chair Ross, for inviting me. And smooth. Okay, here we go. So I'm a scientist at UNC in Chapel Hill in the School of Public Health, and I'm a street drug scientist. I've been studying street drugs for over 20 years, and I have advised the World Health Organization on scheduling decisions for substances, and are currently our labs are currently working with the Food and Drug Administration on the scheduling of Xylazine nationally to figure out where it needs to go. So we're doing the very core experiments. even though I've been doing this for 20 years, I also come to you with humility, because every time we think, okay, we've seen everything under the sun, something new comes out. And I think Representative Cunningham mentioned this. And so what we have encountered with xylazine is different from anything else we've seen in the drug supply. And I'm going to try to talk you through why that is different and kind of what the implications to health are. So just for background, so we run a street drug monitoring service. It's a public service. It's not a research study. And we are grateful to the General Assembly for funding this scientific work through the NC Collaboratory. And we are able to collect street drug samples from public health departments, from EMS, from other health programs, frontline health programs, and analyze them in our lab in Chapel Hill. We've created these test kits, which I can pass around in a moment, which has a liquid in it which inactivates a substance. It's called methyl cyanide, so don't be drinking what's in here. But this is a homegrown innovation, and allows us to monitor the drug supply in real time. 15 minutes it takes to analyze these samples in our lab. So since we started, we've analyzed about 1,000 samples, 954 to be exact, as of Monday, and when we detect new substances in the drug supply, we partner with our labs at UNC and at NC State or Duke and figure out exactly what the pharmacology of that drug is. Is it more potent than fentanyl? Does it work the same? How worried should we be? Some of these substances, we've detected about 240 different substances in the drug supply in North Carolina. So a lot of those don't have any human data on how dangerous is this, or can this even get you high, right? Like that question isn't even answered in a lot of these substances. So we were able to get the lab data right away, and then turn it around to the clinics and veterinary practice, especially at NC State, to figure out what the implications are for actual physicians and others on the front lines dealing with this. Then we turn that around, work with our advertising and communications colleagues to figure out how to package that information in a way that it's going to change behaviors and change people's minds to stay away from some of these dangerous substances. So in doing that, a very brief history of xylazine is, as the speaker before me correctly said, it was invented in Germany about 70 years ago. It was intended for high blood pressure treatment, but it made people too sleepy for it to be a commercial medication. So, give it to the animals, sedate the animals. Now, xylazine holds a very special place in veterinary medicine because it is used all over the world, from everything from kittens to very large game animals in Africa. But unlike the other veterinary anesthetics that are currently available, it does not leave traces of contaminated medication in beef. So it has an important role in veterinary practice because it's safer for animals raised for human consumption than other medications that veterinarians might be using for anesthesia and surgery. So that's the context. It kind of emerged as a potential drug of abuse in Puerto Rico about 20 years ago, and it was around the horse racing circuit that happened. So kind of not surprising, right? And then it started showing up, especially in Philadelphia, starting in about 2006 and getting worse over the last decade. And then I'll take you back to that COVID period. I apologize, but think back to like spring of 2020, summer of 2020, we started getting calls from certain service programs, health departments, clinics all over the state saying, we're seeing a huge increase in wounds. What is going on? Can you help us figure this out? So we went and did some studies and documented that these wounds were increasing. It was when one particular certain service program in Greensboro got a machine that was able to test street drugs through an exemption in the North Carolina Controlled Substances Act. They were able to definitively say that it was the xylazine that was causing the skin wounds. And that was in January of 2021 that we had that first confirmation. So since then, we started our lab, and I want to thank Representative Sasser he's come and visited our lab and has helped us purchase some new equipment to replace some old ones, and has been a great sounding board for this work. So we've tested 516 fentanyl samples from around the state of North Carolina, and about 41% contain xylazine. The map is there, and the black counties are the ones where we have lab confirmed xylazine's presence, but in a lot of the other places, we have about coverage in about half the counties in the state. In the other places, we're pretty darn sure that there is xylazine. We just haven't seen enough samples from those places to be able to say it ourselves. So that's kind of where the landscape is in North Carolina. And this is the sheet I was talking about, if y'all are looking in your packets. Okay, so we also made a recent discovery, and with due respect to the previous speaker, xylazine actually is an opioid, but it's a special kind of opioid, which I'll explain in just a second. And naloxone does work on xylazine. Okay, so we were the first in the world to discover this, and this is something that is very fresh science, and so I'm not expecting anybody to have heard of this yet. It was done by Zoe McElliott's lab on campus at UNC. So I'm going to talk about receptors for just a second, but we're not going to lose each other, all right? Okay. So xylazine, so usually we think about heroin, morphine, these things bind to something called the mu opioid receptor. So the Greek letter mu. That one is what's responsible for euphoria, pain relief, and respiratory depression that causes overdose. There is a sister receptor called kappa. Okay? Kappa is traditionally known for causing dysphoria, meaning the sensations that people don't like. Kappa is what's involved in withdrawal. It has not ever been known to cause pleasure in itself. Xylazine does not bind to mu, it binds to kappa. And this is why it is an opioid, but it's a different kind of opioid than we've been dealing with fentanyl or oxycodone or heroin. So this complicates the picture quite a bit because it challenges a lot of our assumptions about what opioids are and what's in street drugs. So I think there's 3 specific health harms I want you all to keep in mind: wounds, withdrawal, and overdose. Okay, these are the 3 things that we are currently worried about with xylazine, and I'll go through these one by one. Wounds. So the wounds that people have from xylazine are some of the most gruesome that I've seen in 20 years of doing this work and looking at skin wounds from different types of substances. But they can be treated if you catch them early, and they can be treated like chemical burns instead of abscesses. So they spread differently. They occur beyond the site of injection. They can occur in people who have not ever injected a drug in their life. Okay, so people who are just snorting or smoking fentanyl that has xylazine in it, it can appear there. The pictures you see in the media of these gruesome skin wounds are not helpful because what you don't see is the early stages of those wounds when we can intervene, right? When we can say, all right, you're taking something that is very bad for you. Here's how you treat that wound. And that's what I think one of the things we need to move towards is, instead of sensationalizing the gruesomeness of it, is to make people understand what those wounds look like early enough so we can intervene. And why do we need to intervene on those wounds? Because there is, I'm sad to say, unnecessary amputations happening from these wounds in North Carolina right now. We have intervened with physicians on behalf of the patients to say, this is not an abscess, this is not a bacterial infection like you would normally see with injection drug use. This is something different. It needs to be treated different. One of the folks on my staff who's in long-term recovery, the advice he got from an urgent care clinic in Kernersville when he had those wounds was to put bleach on it, right? And then he did that. It set back his recovery for a long time. He finally went to another nurse in Winston-Salem who had family members who were who had addiction, and she was cognizant of this problem, gave him better advice, got him healed, got him on the road to recovery. So we have a lot of misunderstanding of how to handle these wounds at a medical level throughout the state. And we get a lot of calls about this. So I think one of the things we need to think about is if we want people to live with dignity, to not become permanently disabled from a misinterpretation of a wound, we need to do a better job educating our medical providers and our surgeons on what xylazine wound treatment really is like. The other problem with wounds is that people are being denied entry into substance abuse treatment because of their wounds, right? Because the substance abuse treatment facilities will say, we can't handle that wound, that looks disgusting, get out of here, come back when that's healed. And what are they going to do? They're going to go back to using, right? They've taken that step to get help, but they can't get that help, okay? So that's another big problem we need to address. All right, so speaking of treatment, let's go to the second health issue, withdrawal. So withdrawal is, so what we now are dealing with is substances that are mixed with xylazine and fentanyl, right? So you have your typical fentanyl opioid withdrawal going on for, say, 8 to 12 days. And then you're dealing with a xylazine withdrawal on top of that because of this kappa opioid receptor activity. And so what we're seeing in the clinics, and we hear this from clinics around the state, is that their effectiveness of medications for like buprenorphine or Suboxone, when people are trying to get out of treatment, they're leaving early because that medication alone isn't meeting the people's needs who have been using xylazine. Okay, so part of what we're trying to do and the work that we've been contracted with FDA to do is to understand what the pharmacology of the withdrawal is and what what we can do with existing medications to maybe supplement what is already being provided to folks when they go into a residential treatment facility or an outpatient clinic, and see if we can do something to help with that withdrawal piece of it so that they stay in treatment and do something better, make the better choice with their lives that they've set themselves on the path to. All right, so that's withdrawal. Don't worry, this is not going to get much worse. Overdose. I have some good news. So xylazine is not causally related to overdose at this time. And so, like I said, naloxone works on xylazine. The reason why we hear, and not just from our last speaker, but we hear this in the field all the time, that Narcan won't work on xylazine, it's not an opioid. Well, we talked about the not an opioid part, but the middle part of that, why do people think it's not working? Forever, our way of knowing whether naloxone worked or not was when people came back to life, right? They got reanimated, they started talking again. The xylazine, this after the naloxone hits the brain and helps people start breathing again, they may not wake up in the same way for another 45 minutes. And that's the period in which people freak out and give dose after dose after dose of naloxone, and that's not helpful. You don't need more than the 2 doses. What you need to do, instead of like what we've always been looking at is people's reanimation, is to watch people's breathing, count the breaths. And if you do that, you'll see that it is actually working. It's working on the fentanyl part of it for sure, and it's also working on some of the xylazine components. It's just going to take them it's going to take them 45 minutes or something to come back. This is kind of like marrying the field observations with the pharmacology that we have learned. I can further, in the materials on your portal, I believe there's this document, which is a recent report from the Reagan-Udall Foundation for the FDA, which is FDA's kind of scientific investigative arm that convene these meetings. There was a doctor from Philadelphia, which has been hit hard by xylazine, and they actually show results of a study that overdoses that involve fentanyl and xylazine are less severe than overdoses with fentanyl alone. So the time to onset of coma is less when there's xylazine present, and the amount of CPR needed is less when there's xylazine present if you're in that medical facility and the doctors are like counting breaths and doing what they need to do instead of just relying on reanimation. So this is where the discrepancy is between overdose. And so also in this packet, you will find numbers from CDC on xylazine being found in 1 out of 9 overdose deaths in the United States. But just because it's found doesn't mean it was causal in that overdose death. And that's the distinction that we've been asked to kind of tease apart in our scientific studies. So I'll I'll just kind of wrap up here with talking about what's coming next, right? You'll see this paper in there, and this is like a printout from the FDA website. This is a description of our ongoing project. It should be like attached to maybe this page, I think. Right, Tammy?
Yes, sir.
Okay, you got it. Third page. So you'll see there's a very difficult word to pronounce on here, dexmedetomidine. I mean, it took me months to learn how to say this, so I want to say it again because I learned dexmedetomidine, okay? This is a very similar sister molecule to xylazine, just a couple of molecules different. We have already seen it in the street drug supply right here in Wake County and in other parts of our state. It is also not a controlled substance. So the reason why FDA insisted that we look at both of these together is because Dex, I'm just going to call it Dex if you all don't mind, is a very important very important medication in the hospitals. It's called Precedex. If you have neonates who are on respirators, this is the medication that's used to keep them sedated while they're getting oxygen and oxygenated. So on the federal kind of scientific level, scheduling xylazine without scheduling Dex is a very difficult question. And if there is differences between these nearly identical molecules, then the science that we've been contracted to do is intended to tease those apart to see if there is to understand what the scheduling implications were. If Dex were to be scheduled all of a sudden, it would cause massive disruptions to the biopharmaceutical industry that uses this for cancer research. It's also used as a medication in schizophrenia and would affect mental health treatment as well. So scheduling is a complicated beast, and there are unintended consequences. So we were basically told, here's what we can see is coming next. Can we do something to stay ahead of the curve for once and figure out how to address both of these at the same time? I'll just close by saying on the last page, there's current needs of what we need to do. I think wound care is really important. These are the xylazine test strips. Where did I put the other one? And there's some basic research that needs to be done. There's only two. You can go on Amazon and buy xylazine test strips, but I will tell you they are terrible quality. They are not accurate. So we need to protect the consumers as well. And there are like a couple of legit brands of these. And they can vary from lot to lot. So part of what we're trying to do in our lab is to figure out which of these test strips are actually the accurate ones and recommend only those. I think we talked about oxygen and there's some folks in the community who are experimenting with canned oxygen, because I agree with you, mouth to mouth is a problem, but re-emphasizing rescue breathing and breaths is really important. We need to figure out how to get doctors to understand how to treat xylazine differently from everything that's come before. It's not that complicated, but we need some clear direction and bringing folks together. Maybe throw some CME at it, all that. And then finally, we're continuing on with the research and want to make sure that we include our veterinary colleagues to understand kind of what the implications are for livestock production in our state. So thank you. I'm happy to answer any questions. Sorry.
Questions? Representative Pearl.
Thank you, Mr. Chair. I'm just wondering, in your data that you're capturing, are you getting much cooperation, or are you working closely with the Chief Medical Examiner's Office in order to make sure that their suspected overdoses that they're finding support what you're
Absolutely.
sharing with us?
Yep, we exchange. We send all our data is public. We send our data to them every day, or we put it in a place and we've sent them the link to it. We regularly talk with them, see what they're seeing. We compare, what drugs are emerging in the bodies versus on the street. Yeah, we work very closely with them.
Representative Sasser.
Oops, sorry.
Again, I'll follow up on all the great work that NAB is doing. He makes UNC Chapel Hill, makes us alumni proud. because he's at the top of the food chain. And thank you for dumbing it down where I almost understood
I
what you were saying.
tried. I tried.
So, but thanks for all the great work you do, and we appreciate your recommendations and your advice, because you're up there where the rubber meets the road, and we're usually 2 or 3 years behind. So, thank you for all you do.
Thank you. I appreciate it.
Representative White, your light is on.
Since our law enforcement was not aware of some of the things that you said, how are you all getting that information out to law enforcement or the people that are actually working out there in the community every day, public health, local physicians that's oftentimes might see these people before they would get to a university hospital? Could you share a little bit on that?
Absolutely. We think that public education communication is incredibly important as a state school. Like, this is our responsibility to our citizens. The form in which a lot of it has come is with the county level opioid settlement meetings, where folks are trying to figure out how to spend the opioid settlement dollars, have law enforcement, have medical providers, all sorts of folks from around the community, faith community also. And so we regularly present at those meetings, Wake County, Randolph County, Dare County, in the West, all over the place. So we're happy to do more of that. We're happy to work with others to get the word out. We're kind of dorky scientists, and so we work with our advertising colleagues to try to do better. But if you have suggestions, we'd be honored.
Representative Cunningham.
Thank you, Mr. Chair. My questions are related to capturing data. I want to know more about the wounds, the extensive cost of the healing process. Where does the financial burden finally land? Because we know that now we've expanded Medicaid. Is that going to have an additional impact going forward as we try to keep the community well and healed and in treatment?
That's a really good question. So I think the medical system as it's currently set up is not equipped to deal with these wounds. So these wounds take 2 to 3 months to heal. I've seen them heal. It does happen. But it takes dressing changes every day or two. So you have to keep it wet. You have to keep it covered. The bandages, so it takes a little bit of skill, especially at first. There's going to be some skin sloughing off and some other things. So right now, we don't have a good paradigm for community-based wound care. Usually we've been treating abscesses, which are bacterial infections, which you drain it, pack it in, and then it heals, right? Couple follow-ups. But what they've done in, for example, Maryland, when they've faced the same problem, is to have traveling nurses and traveling trained community workers go and help with these dressing changes. And what's been really fascinating is, like, in the process of doing those dressing changes, those folks have connected with the people who had been using drugs in a deeper, newer way. So I don't know how to create that system. The Maryland folks have offered to come down and talk to us. But I think that if we just assume that we're going to shift all the costs of the medical system, that's gonna raise some flags. But I think we can do this in the community.
Representative Hawkins, I didn't see you way back there in the back.
No, you're fine. Thank you, Mr. Chairman, and thank you, Doctor, for such an amazing overview of the problem. I wanted to hone in on a couple things. Not Dr. White. I mean, she may be Dr. White. But Representative White mentioned the education. Nurse White. The education portion of physicians. We have the AMA, we have the university systems. Have you had any conversation? I wanted to ask, had you had any conversations with any of these areas? I have a couple follow-ups, but I did want to ask that question and what their reactions to you has been so far.
Yeah, so the North Carolina Medical Board released guidance on overdose and Xylazine last year, citing our data. So we're in communication with them. It is hard to get doctors' attention, nurses' attentions. I think like a one-day convening could be cool, and having pieces of that be video report outs, CME, continuing medical education that gets pushed, kind of make it as easy for providers as possible. Give them protocols that are like easily adoptable. here's something that you can just bring into the hospital and implement right away with materials that are already in the hospital. It's a lot of like logistical work that we can do to not just get the word out, but actually get it to the point where physicians are changing their behavior, so we're not amputating unnecessarily.
Well, yeah, that was actually my lead-in, is because you talked about when substance users leave the facility early. Like what? So what are they? How early is early? Are they leaving within hours? Are they leaving within days? And then you're seeing a dramatization of the wound within that time. Like what does that look like? Because it sounds like the less education that doctors have, the more the problem is going to persist. And that's why I asked the systems question around how fast and what kinds of goals can we put around that? Because if we don't, we're going to see a lot less, especially in less resourced areas.
Absolutely. So I think there's two types of places where folks are leaving against medical advice. So one is you go into a hospital, you have this like ghastly wound that you've been hiding for a long time. I've been in the hospital and I've seen this happen. And people, like the entire medical staff on the floor, will come to look at these wounds because they're so atypical and so dramatic. Wow. And it is incredibly devastating to that patient who has finally uncovered her wounds to be there and get help, to be like ogled at that way. And so there is kind of this instant like, oh hell no, I do not want to be here, right? There's that feeling. And then when the physician comes in and says, you need to do this, you need to stop using drugs or else we're going to amputate your arm, right? That's not setting that patient up for making a good decision. It is a threat. And losing a limb is literally one of the most drastic things that can be done, right, to a human body. And so people will leave because they don't want to lose the limb. And so I think there should be better way. I think there are physicians in our state who are doing this well, who are compassionate and can speak that. So that's one side. And then, so you asked specifically about how long people are staying. So in that emergency kind of tertiary care hospital setting, it can be like hours to a day. They're out, right? Because of the way that they're not getting help. And then the other place where people are leaving early is addiction treatment centers. And that's because of a different issue. So if they get in, if their wounds are okay enough, then the medications we have now are not quite as good as they need to be for treating the Xylazine withdrawal on top of the opioid withdrawal. Mm-hmm. So we're talking about like 1 week for maybe the opioid withdrawal to go through the system and another 2 to 3 weeks for the Xylazine withdrawal to go through the system. Where we see that drop off is between the first and second week. Yep. Because the Xylazine causes this anxiety and agitation, the withdrawal does, that makes people want to leave. Sorry, that was a long answer.
No. That's a good answer. Because actually you're leading right into my next one. I have two more questions, Chairman. You talked about the nuance between Dex, and thank you for shortening that for me, Dex and Xylazine, and the complications that sort of from cancer to, neonatal to you name it. One of the things that sort of pops out to me is, if this is available online or in stores, or, Amazon, I'll just pick on Amazon, for example. Are we working with or have any idea around working with some of these big box operations for them to have some responsibility too? Because it's passing through their mechanism to get to said person. Is that on the radar at all? Because, you're right, because scheduling it and trying to figure out those nuances is going to take a while, it seems. But it seems like we have an immediate problem with people being able to access things very readily. And so y'all had a really good discussion while I was driving in. I was listening online. Thank God for technology. But it does, the entry point is a problem, but it doesn't seem like we're attacking that at all. And I wonder, has that come up in any of your conversation or research about ways to mitigate?
Yes, it has. So I'm not speaking on behalf of the FDA. Let me make that very clear. But they do have divisions that are dedicated to interdiction of male-based Xylazine specifically, because there is like the veterinary regulation on the retail level, but it is also a adulterated and misbranded product on the import level. Right. So there is actual federal legislation, and there are agents working on that interdiction now. I don't know the full kind of connection between DEA, FDA, and all the other CBP and all the other agencies, but I do know that I've met the folks who've been working on that, so I know that's being done.
Okay, last question. You talked about, and thank you for the update, that Xylazine, and Narcan, naloxone, it does work, but it takes a while because of the, sort of receptor relationship. In those instances, for example, in Durham, in addition to having law enforcement go out on these calls, we have care teams that include substance abuse professionals and other people that are non-law enforcement that potentially could wait the 45 minutes while a law enforcement officer is going out to, save the world in another different part of the county. Is that something that you think could be effective? Have you heard of this model? Is it being practiced anywhere as it relates to this particular issue? Because, Narcan and naloxone in experience, as we've heard, is really effective and a go-to. Lots of people, as you heard the captain mention, everybody carries it, et cetera. But I wonder, as a way to make sure that there's a professional on staff who is aware, because we are putting a lot on law enforcement to add this to their plates. Do you suggest, or have you heard of this type of care, and do you think it would be a good option?
I have not heard of that before, but that sounds like a creative solution. I think anytime where we can unburden the healthcare system and law enforcement to go take care of more urgent things sounds like a great idea. I don't think I've heard about that, but that would definitely be worth looking into.
Okay. Thank you, Mr. Chairman.
Representative Baker. Sorry, I didn't see your light.
It's okay, sir. 2 questions. One is, I guess, directly in your wheelhouse. It's important for us to get the physicians already in the field trained, but I don't know, have they updated the training courses for pre-service doctors to include this piece? And if not, how can we begin to, even before they enter, get them trained in terms of all the information that you've given us, so that when they enter, they're actually already aware of what this looks like and can be more quickly able to respond. And then the second question would be, do we work with DHHS to work with public health, our public health departments, to ensure that this information is getting out to the community, to our first responders, and indeed our users, so that they can also advocate for themselves?
Great. So the first question on pre-service trainees, it's not something I've given a lot of thought to be perfectly blunt. We have residents and fellows who have their MD before they're practicing come through, visit our lab, which I invite all of you all to come by anytime you're in Chapel Hill, or maybe call first. But I think, a lot of interest we've seen in this information has been among the younger physicians. So I had not really thought about kind of what that training program would look like and the process for updating that curriculum. So sorry, I don't have an answer on that.
So let me ask, as a follow-up to that, then point us in the right direction of who we should be having the conversations with, because I think it's critical. As an educator, the trends change. And so where we've tried to be proactive with those that are coming into teaching is making sure that they are abreast and trained of the issues concerning education. I think it's incumbent of us to look at that very systematically when we're talking about physicians. And so you may not have the answer, but if you can point us in the right direction, the medical society or whoever kind of oversees that piece, I think it's important that be done in a systematic way.
Great. So I think the medical society would be a good place to start. The North Carolina Society for Addiction Medicine has physicians who do trainings of trainees. I think they would be a great resource, and I've been in close touch with them, and I'm doing the keynote at their conference in a couple months in Nashville. And then we only have a handful of medical schools in the state, and the amount of education on addiction in the programs is small. And so there's probably one person at each university who's kind of in charge of that day of education. We could probably do better.
Gotcha. And the public health piece, would you say that working with DHHS would help us with getting this information out? Because again, just last night, no mention of this. And the purpose was to make the community aware of what we were dealing with.
So DHHS has been very strongly supportive of this work and has even funded pieces of it, including some data dashboards and some other work that we've been doing trying to get this information out. The drug checking programs of having public health frontline programs test the street drugs is what led us to being able to pick this up early and get ahead of it. More ahead than we usually are, let's just say, and be ahead of dexmedetomidine and whatever else is coming next. And so I think the drug checking services is a paradigm changing kind of relationship that some of these frontline programs have with the people who are using. I mean, how often do you go in somewhere and see people find out there's xylazine in their drugs and watch them throw it away, right? So like the same programs that are having to, that when people find out there's xylazine, because so much of it, people don't want it in their supply after they hear about wounds and everything else, that some of these programs have had to figure out ways to dispose of controlled substances because they're just used to taking back dirty, cleaning up dirty syringes and other things like that. So
That's good.
I mean, the drug checking, I think, is something that DHHS has been supportive of, and wound care kits, I think, would be really important to reduce the burden on the medical system.
We've got two more lights. I saw Representative Cunningham first, so we'll get to.
Thank you, Mr. Chair. I wanted to remind us that when the LMEs and the MCOs took over substance use and the Medicaid population in the state and got those contracts, that when the Narcan distribution kicked off, it came through the LMEs into the communities, to the police, to the EMTs, to the fire department. And that was a public health initiative when it kicked off. And I would expect to see the same thing coming from the Department of Health and Human Services, as well as the public health, is to help with the distribution in the community and also to help with communicating and collaborating with the local entities. One of the things, when you talked about wound care, I've worked the burn unit and I worked it for years, and they are horrible wounds and the amputees will happen. But if the medical society and some of the other entities could collaborate to recognize a team that specifically treat these wounds and coordinate that care, we would see less amputations and better quality and outcomes of those wounds. And that would be very less financial on our budget.
Absolutely. I couldn't agree with you more on that. And I think the naloxone availability also is very restricted in North Carolina right now. 81% of the frontline public health programs say that they're rationing it because we've kind of placed a lot of money on the branded version of it instead of the cheaper versions. So I think, we're facing this shortage of the life-saving drug at the same time on the front lines because of corporate interests. But it's a problem.
Thank you. Representative Pearl.
Thank you, Mr. Chair. My question is kind of along those same lines. I hope that our detox facilities or our substance abuse care facilities that offer these services to these individuals, I hope we can maybe add some wraparound services that will treat wound care. I certainly hope that there's that we change our business model so we're not turning away anyone that needs those services to a hospital to provide wound care who is not prepared to offer the detox component. That's right. It's kind of which come first, the chicken or the egg. Mm-hmm. Both of these services probably need to be It needs to be a collaborative effort for those individuals that suffer from this particular substance abuse. The days of back when I worked narcotics many years ago, we were cutting, or I was finding substance that were used or stepped on or cut with isotol, other type of harmless.
Oh, he's still around a bit.
But this is scary. This
It
is very
is.
scary.
It's sad, huh?
Thank you, Mr. Chair.
Representative Sasser.
One brief statement. We may seem a little overly concerned with where everybody else is doing their job or not. If we get this drug off the market, we don't have to worry about all this. So we need to look in the mirror and do our job and get this drug off the market.
No other questions? All right. Thank you, Doc.
Thank you. My pleasure. Sorry, I have a lot of paper.
Catch these if they fall.
I think that's
So,
yeah. Show and tell.
thank you. All right, we're doing pretty good on time today. Next up, we're going to have a few speakers that are going to talk to us about a different topic. And I'm hoping they're here. I did not meet them earlier, but is Casey Temple? Yes, sir. All right.
Thank y'all for having me. Still underdressed. First thing when I walked in, I didn't have the coat on. I don't have a lot of big words and stats and stuff like that, but I do have my own experience with being a child growing up and smoking marijuana. I always struggled with feeling like I fit in. And when I was in high school, I got pressured and asked many times would I like to try some marijuana or smoke a little weed. And at the time, all throughout school, I always made excellent grades. I was so good in school. I thrived in learning. I was a teacher's pet. I was a loner. I stayed to myself. And a lot of times in high school, especially in my 12th grade year, I was pressured a lot in the bathroom. Every time I went into the bathroom, did I want to smoke some weed to relieve any stress? And I always said no. But in December of my high school year, I smoked some weed for the first time. And my life took a drastic turn downhill. From that point forward, it seemed like it helped me to fit in where I didn't necessarily fit in. And it helped me to be okay with who I was. I didn't know it then, but I know today, being in recovery over 10 years, that I was uncomfortable in my own skin. And so this marijuana helped me to be comfortable in my own skin. And as a result, I became a social smoker of marijuana, especially on the weekends. As it progressed in my late teens, I caught myself smoking by myself because I had to have it. I became quickly addicted to it. By the age of 20, and I didn't know it then, but I know now, I was suffering with depression. And so this marijuana, I thought it was helping my depression at first, but it soon started having adverse reactions with my depression. And at the age of 20 in May 2000, I stuck a 12-gauge shotgun under my head and I pulled the trigger. Not necessarily because I wanted to die, but because I wanted the emotional and mental pain to cease that was going on in my head. And I truly believe that marijuana took away that inhibition to pull that trigger that day. That it, as a depressed young adult, marijuana is a depressant. And so at that time, I didn't realize that it was making my depression worse. And at that time, I had no ability to tell another human being how I felt. And so I used the marijuana as my medication. I was self-medicating. And as a result of that gunshot wound, I continued to use substances. I've had 36 surgeries up to this date, and marijuana opened the door to so many other substances that I tried and used. And so I just want to stress the importance of marijuana being legalized is not, in my opinion, the way to go. If I had never, there's no doubt in my mind looking back on it, what I know now, and my wife is going to talk about what our son's gone through, but there's no doubt in my mind if I had never used that marijuana in that bathroom that day, that I wouldn't have done any of the other things that I would have done. And for sure, I would not have stuck a shotgun to my head and tried to end my life. And I'm not going to take a lot of time. I just wanted to share that with you all. Thanks for letting me share.
Thank you. And I think you mentioned your wife is here. Is that Tisha?
Thank you. Hello, everybody. I am excited to be here. Maybe not about what we are here to talk about, but because I know that this is where solutions are found. And so I'm very grateful to have been asked to join today. My name is Tisha, and I'm a woman who is living in long-term recovery. What that means to me is that I have not found it necessary to use any mind or mood-altering substances since July the 26th of 2014. I am a formerly incarcerated individual. I am also certified with the North Carolina Addictions Specialist Professional Practice Board as a certified alcohol and drug counselor, and I am the Chief Resource Officer for a nonprofit that was founded in Johnston County, North Carolina. We serve 300 to 500 individuals on a weekly basis. We have recently opened 2 Christ-centered recovery homes that are serving our community well. We have extended to 60 other locations over 3 years. So what we are doing is working. We're thinking about opening a community center. Well, not thinking about it. The thoughts are in place. We're just looking for a building. But I think about how our team serves our unhoused neighbors and how I know that people have contacted us because they have wounds and how our team loves them right where they are. And so when I hear the work that is being discussed here in this room, I just want to say that we are alongside of you. And if there's anything that we can do to help anyone, please. I've got some cards and some materials about who we are and what we're doing. Contact us and let us love your people. I'm here today to specifically talk about our son. So I would love to be able to tell you that when a person finds recovery, that they are able to always say this dysfunction ends with us. But unfortunately, that is not our story. But I do know that my son is given every opportunity and access to care that I can become aware of. So today I'm here to share with you my mother's heart. COVID happened. Our son, who is very quiet and meek, attends youth group and church and has a ton of support and has probably been to more AA or NA or Recovery Alive meetings than most adults because we took him alongside of us. Stayed at home for a year, through Virtual Academy, maintained very good grades. When school reopened and he was going into his 10th grade year, unfortunately, he was not able to say no when he was offered marijuana, and things spiraled out of control very, very quickly. We had noticeable changes in behavior, signs of depression, increased isolation, and disengagement from activities. Our son, who was very interested in soccer and football, became very interested in isolating in his room and making bad decisions. Academic decline. He went from passing to failing all of his classes. His disruptive behavior and disrespect was not only happening in school, but also within our home where he was not taught those values. We were discovering marijuana vape pens on multiple occasions. I mean, it seemed like the more we found it, the more there was to find. The hiding places were stunning, even to a woman recovering from opioid use disorder who spent 10 years in active heroin addiction and homelessness. I'm like, I cannot believe that you are this clever. I was afraid. of what I was seeing happening to my child and the way that he was able to hide it. These behaviors are not something that he taught himself. These behaviors were learned. At the one place that we were sending him to spend most of his hours, do not think that I'm telling you that it is all someone else's fault. My son plays a role in his decisions, and we hold him accountable for those things. However, we needed a lot of support that I did not feel like we were always being given. And it is disheartening, to say the least. He was exhibiting violent behavior due to cravings from this illegal substance. So there were a lot of periods of time where he was at home and not at school, and it was not readily available to him in our home. And him not having it when he was at home caused a lot of rages and a lot of fits. Threats of self-harm led us to having him involuntarily committed. He stayed 28 days at an inpatient behavioral health treatment center called Carolina Dunes. Despite time there away from the substance, he came home, and we were able to engage him in community resources. We even went so far to have an intensive outpatient therapist come to our home 3 times a week to do family and behavioral therapy with our child. Despite initial improvements, his behaviors resurfaced at school. Lack of healthy coping mechanisms, and due to his over-reliance on marijuana, our son then began to commit crimes. Escalation to dangerous activities, including posting concerning content on social media, stealing a car, possessing guns, and fleeing to Ohio. Because this was not accepted inside of our home, my child was not able to make good decisions because he's using a substance that is illegal and affecting him in a way that he had no control over. 2 weeks in a detention center in Ohio, I can remember the judge saying to me, because he crossed state lines, right? So he, to be sure, has to come back to North Carolina to face his charges. But he was being held in a juvenile detention center in Ohio, and I was very aware that there was no detention center for him to be held in here. Treatment had not worked. Not inpatient. The intensive outpatient in our home and connections and access to care that we were providing him had not proven effective. And when that judge in a Zoom call from Ohio asked us when we were coming to get my son, I said, we did not get him there. I need you to help me. A very hard decision is to not go and get your child. 2 weeks later, my husband went to Ohio and picked up our child. And he was returned to our home to wait months to stand in front of a judge when my heart felt like, when I get there, they're going to help me. Even if they have to put him on probation and let him pee in a cup, because we are constantly going through it in our home because I'm scared that he's going to have some other type of substance attached to the marijuana and I'm going to find him overdosed in our home. He was placed on probation. It took months for that to happen. I would love to tell you that that is the end of our pain. We are not there, and I'm trusting God with the outcomes. 3 felony charges were turned into 1 misdemeanor. Concern for the rest of his life about how these decisions that he made as a child through his connections to peers in a place that I was sending him because I want better for him. Now I'm scared what is going to become of him as an adult because he already has a record. Making bad decisions by using marijuana. He has quit school. I promise you, I'll walk through it. Back to virtual academy, conversations with so many school officials. And honestly, I just don't have any control over it, right? I'm a parent and I want good things for my child, and I provide those things for him, but ultimately I don't have any decisions. He has put a substance into his body that has caused him to cross an imaginary line that he feels like that is his answer to deal with his feelings and emotions in a healthy way. And yet everything that he is doing is extremely unhealthy. His ongoing struggle with addiction causes fear in my heart as a parent because of the potential for polysubstance use, him not using medication to treat his depression and anxiety in the right way, and not talking to other people. Again, I want to say that I do acknowledge that my son's choices are ultimately his responsibility. But it is also our responsibility to protect a child that has not been introduced to marijuana from ever being introduced to it. I'm very grateful for the programs that are operating. I know that there are prevention practices in place. On a weekly basis, I said we serve 300 to 500 people. That's adults. We're also serving 60 to 75 teenagers on a weekly basis, where we're providing a safe place for them to be able to come to us and tell us, it's okay for you to tell me what you are doing. It's okay for me to support you where you are. But before they're becoming teenagers, we're also providing a safe space for our young children so that we can talk to them before this world does. My child can get better. My husband and I are proof of that. With support systems that we have from our church family at Temple City Church, and building a recovery community that is based on the Christ-centered 12 steps, and also understanding that people don't have to have a relationship with Jesus for me to love them, because to be sure, if they stand close to me long enough, I'm going to ooze out onto them. And so none of it has to be attached to whether or not they believe or they don't believe in the same things that I do. It just means that I'm willing to show up and love them where they are. And I will continue to fight for my son, and that is why I'm here to tell my story of how marijuana use has affected him as a teenager. And I can only pray that he finds recovery so that one day he can advocate on someone else's behalf. Thank you for letting me share. Yes. Thank you.
Thank you for that testimony. And also, I want to just thank you for the work that you've taken on. It's as we've all seen here in this committee, as we've dug in. It's a mammoth task, and we need more people like yourself. And I just want to thank you for that. Is Carla Pearce? Yes. Okay. Our last speaker is Carla Pearce.
Thank y'all for having me. I feel an honor and a privilege. My husband is a pastor of a 1,000-member church. He gets to speak every day and all week. And so I'm not one of those, but I'm very honored to be here. So I have two perspectives. I'm a school social worker for 25 years in many different schools. I serve elementary, middle schoolers, and high schoolers. I became an advocate very early on. As far as I can remember, even in elementary school, I always had an empathetic heart, and I'm very much an empath. When I do home visits, I am in the trenches. I do about 10 to 15 home visits a week, serving multiple schools, seeing different cultures. Our county, Johnston County, has expanded so much. I am aware of the effects of marijuana use, both as a school social worker and a personal experience. I want to share both. I started delving into this and doing my own personal vendetta when it started to affect my life. So I want to say that through experiences, school should be a safe place. School should be a place where our kids are worried about their education. They come from so many different backgrounds. The ACE scores, I don't know if you've heard about that in the Mental Health Society, but ACE scores are something that we all have, whether we deal with domestic violence at home, seeing drug use, all of these things. As a school social worker, I have reported marijuana use, and I have been told in this field by experts that I really don't have anything to report unless the child has access to it. So as long as it's put up in a closet, they're not really worried that the parents are actually doing it. Last week, I was in the front office of one of my schools. I almost got a contact high with a parent signing in their kids late. I was really shocked that, nothing is said. It's almost like we just excuse marijuana on every level. That's just the lesser drug. It's the lesser evil of the evils. My questions have been, I'm going to tell you about my acronym for MOM. My daughter graduated in 3.5 years. We moved to a smaller area of our county just so our kids could attend a smaller school. There's 120 seniors in their graduating class. We thought this would be a great avenue, a great choice for our kids. We had high hopes for all of them. We have 3 biological, and I've also taken in 2 foster kids from my experience in school social work, one being a first generation graduate. Very proud of that. But now MOM, the acronym started to stand for Mom of a Marijuana User. And my son comes from a 2-parent home. My husband's a pastor. I'm a school social worker. My husband coached all his teams. We had high hopes for our son. And at the age of 15, he was introduced at school in the bathroom like Tisha Temple to vaping and marijuana use. It was supplied at the school. Apparently, kids can go on Snapchat. That disappears very quickly. If I were to try to take a picture of the Snapchat transaction, the person selling would know. We do have SR officers at all of our public high schools in our county. However, they're not allowed to search an individual, not unless they have reasonable cause. My son's senior year, his car was in the wrong parking spot. And when asked to be moved by the SR officer, he searched his vehicle. He found a 1/2 ounce of marijuana concealed in an ibuprofen bottle. And my husband immediately went to the school. We knew that it was a problem. We didn't know the extent of the problem. My husband begged for my son to be arrested. He wanted there to be consequences. He wanted there to be accountability, and nothing was done. He was 17 years old at this time. As we started to try to be excited about him on the golf team as the #1 seed, we should have been going to a golf tournament the very next week that he was not allowed to be a part of. His senior year was crushed by marijuana use. My husband went to the school, asked for him to be arrested. Apparently the law states it has to be at least over a 1/2 ounce. He had right at a 1/2 ounce in that medicine box, in the medicine bottle. My husband was stunned that there was going to be nothing done. The only reason he was put on juvenile probation is because he had brass knuckles. So brass knuckles carried a stronger weight, being considered a deadly weapon, than illegal marijuana use did. As we should have been applying for college applications, we started making a contract with our son that to stay in our house, you have to follow these guidelines. You have to do these. This is not acceptable. We don't supply it. We don't have it. My husband and I have no chemical dependency. Our son's been given every opportunity, involved in youth group. I served in youth group for 3 years, was stunned one evening, just want to bring this to the forefront, was stunned one evening when we had a beautiful service with a lot of conviction, and I watched young people go take the vapes out of their pockets and lay them on the altar right there in church. We are facing an epidemic, folks. It is everywhere. I don't know about you lately, but I've been at TJ Maxx and I smell it permeating from the car beside me. It is so, let's don't talk about it, that just don't talk about it. It's like smoking cigarettes or having a drink after work. It is affecting everyone and everything. And I talked to a parent last week who called me about her son and said, Miss Carla, you're the school social worker. What should we do? I can give them a list of providers. I can help. I can link to resources. I can even give my own personal testimony. Her son, and last weekend, her son and another student who were provided by a student at the high school after being asked, were provided with the marijuana, were smoking it out the bedroom window. So, It's everywhere. I see it on a weekly basis. We can have sniff dogs come to our school, but they're not allowed to sniff the students. They're allowed to come in. They can sniff the lockers or if there are book bags in a classroom. However, catching individuals is very hard. So if somebody has it in their sock and I see that and I report that, we could ask to see that. But if that student has transitioned that stash into his pants or in his pockets, we're not allowed to search. Only administrators are allowed to search. I'm really perplexed as to why our SR officers are not more emboldened and able. It's almost like I feel like our SR officers are just sitting at the school because of school shootings, and they're just there because now we feel protected because we have the SR officer there. There is so many proactive things they could be doing. They could be doing classes. They can be doing proactive interventions. They could be sharing. They could be teaching these kids since from middle school up the effects of marijuana use and drug use. So I want there to be more done. I've also have the question, I want to pose the question, why are we not testing our athletes? We're testing them for hydration, but we're not testing them for drugs. This is a problem. They're not allowed to test. I had a parent last week show up at the school and wanted us to test her child. We said we can't do that. So she brought a drug test and was going to take him home and test him there. So there's so many restrictions. I also wanted to ask one of my SR officers at one of my schools, what's the deal with the vaping? Vaping is happening in a lot of the bathrooms across the schools, and it's in buildings that are typically not right. They're adjacent, so they're in your ag buildings, your agriculture, your buildings that are detached, because people aren't really aware. The SR officer's not in that building. So every time a child goes in the bathroom, they're at risk for being asked or posed, do you want to hit the vape? The dab pens are much less expensive. You're spending $45. It's going to last you about 2 or 3 weeks as opposed to buying a stash. Now, you have to understand, my son went to football. He worked a full-time job, and he was at home, and still he found time to do his drug of choice, which would be marijuana. He tested for nothing else but marijuana. It took his whole senior year away. It took a toll on my husband. It took a whole toll on me. It took a toll on my younger son, who worships his brother. I have removed my son into a private school, hoping for a better outcome, hoping that I can protect my child. I can't protect my child at school. I can only do what I can do at home. I have zero control at the end of the day, and we all are powerless. So we're doing our best. I update you to say that my son has been clean going on 11 months. We are holding him accountable in our house. He's now 20 years old, so if this were to happen again, he'd have to find somewhere else to live or just live his life, because we've done all that we know to do personally. But professionally, I also have major concerns, seeing it on a weekly basis, reporting it, and there seems to be nothing that is happening across the board. Thank you for letting me share.
Thank you. And thank you for the work that you do also. We just have just a few minutes. If you want, we can have a little committee discussion.
Chair Ross, can I just ask Mr. and Mrs. Temple a question?
Sure. That's up to them if they're willing to answer.
First of all, I'm not going to cry. Congratulations to you both for living a life of victory, okay? And overcoming all that you've overcome. And know that the trials and tribulations that you have overcome is for those who can look at you and say, I may not be where I want to, but thank God I'm not where I used to be. I want to say that first. And both of you indicated that you, Mr. Temple, that perhaps you had depression that may have been undiagnosed. And then you, Ms. Temple, you mentioned about your son not taking his depression meds. Do you think that there is something more that we need to do in that lines? Because oftentimes we know that drug use can be tied to undiagnosed mental health issues. And I want us to be careful not to just look at marijuana usage in a vacuum because it often is tied to some other things. And Ms. Pearce, you didn't mention that about your son, but is there something that we should also consider when we're talking about marijuana use and behavioral health or undiagnosed depression or?
I strongly believe that substance is not being readily available is the first course of action.
Yes.
Person-centered care is extremely important. My disease is not going to look like my husband's.
Yes.
My husband's disease is not going to look like our son's. And so it's truly about forming a relationship with an individual and learning what is going on with them to provide a treatment plan that is going to help that person find long-term recovery. And for some people, and most people, as we know, that it is a dual diagnosis. It's very difficult to understand which one came first. Was there depression before substance use? Was there substance use before depression? And those things are important. But if we don't remove the substance, we're not going to be able to treat the depression.
That's good.
Right now, that's where we're. And so right now, my husband and I are healthy. I have suffered from seasonal depression and other things related to mental health disorders. However, today, I use an abstinence-based program of recovery. I support all pathways to recovery, right? But we can relate to my story. But my husband is able to share a wonderful story of how his medication is a very vital part of his recovery.
Yes, ma'am.
And so I think that when we are talking to our teenagers or our children, right, I think that we should start talking to them way before they become teenagers, because the world will talk to them. That if we can recognize any mental health problematic issues that may be arising, that if we start to address those issues before our children are introduced to readily available illegal substances, which are changing the course of their lives in a negative way, that we can start addressing the issues with mental health, and then we ain't got to worry about which one came first. Because we're being a part of the solution, not the problem. Yes,
Thank you.
Representative Cunningham.
Thank you, Mr. Chair. I'm going to speak from a perspective of a healthcare provider and scientific. So, if you look across America and the entire world, you will see addictive personalities, which we beg to differ to dig deeper into whether it's a genetic link. We know there is one for alcoholism that can be identified. And so you have numerous variables that come about, whether you're addicted to food and you're obese, or whether you're addicted to being skinny and you're bulimic or anorexic. So everything is connected. It's not independent. The addiction is not independent, but we must recognize that it's numerous variables that play a role, and marijuana by itself, most of the time, used in the medical profession. It's been used for years for narrow angle glaucoma. It's been used for years for chemotherapy to curb the nausea. But that's in the medical aspect of it. In most cases, when the marijuana is grown and is pure and not mixed with any other derivative, then in most cases, it's not going to harm you to the extreme level. Now, I have not tried it, but I've seen it used in the medical aspect, and moving to the SROs for us to safety, that is very important that they're there for that. But you must also remember that the children in the public setting still have rights, and their parents have rights. Whether or not those children are searched in those premises, it is still public property, but you still have to protect their rights. Thank you, Mr. Chair.
Mr. Chairman, if I could, I just want to introduce someone that's here today. Paul Scott won the primary in District 111, and I think most likely will be joining you all as a colleague next year in the House. He's from Rutherford County, a great guy. He's an pastor. That's why I made sure to introduce another member of the pastor caucus over here with Representative Sossman. Currently serves on their school board, and I just wanted, he has an interest in this area as well, and I just wanted y'all to get a chance to say hello to him. You'll be seeing him starting in January next year, I suspect.
Thank you, and welcome to Raleigh.
He's a tough chairman up there.
Yeah, we try. We're coming close on time. Is there any other comments? And then I have a couple of announcements. Just. All right.
I had an overall question for the doctor about, and I may be not understanding it completely, but what I heard you say about Xylazine and Dex and the familiarity with both of those, except for a few molecules, and then we talk about banning one of them and the second and third order impacts, especially with the livestock production angle to it. I'm not sure that I understand or have a clear thought process about how we as legislators are supposed to address an immediate impact facing human beings, and then also take into account the time that it takes to process all of those other factors. And that may be a big question for right now, but if we can have a sidebar and maybe put that on the agenda to maybe discover more of what you were talking about in that space, I would appreciate that.
Thank you. All right. In your packet, there is a listing. One of the members of the committee had asked for a listing of what some of the other states are doing in reference to the Tianeptine. So that is in your packet. Also, Representative Sossman has organized a tour for committee members if you want to join. This tour is the, I almost hope I say this right, Xylazine Lab. It's over in Durham. And I think this is the same lab that was referenced by I think it was ALE earlier. This is a lab that some of the law enforcement agencies are using. It's state of the art and has a lot of great tools to their disposal or at their disposal that we can maybe call on down the road as we go forward. If you would like to go on this tour when we go, it is Friday, March 22nd at 9:30, and just let my office know, and we'll add you to the list. It should be in your packet, but we will send a reminder if. Okay. Okay. I've been asked to remind you also to be sure to get your travel reimbursements in. I'll get 30 lashes if you don't. So, all right, if there's no other discussion at this time, we'll go ahead and adjourn this meeting. Thank you all for being here today.